Now I'm going to take a few minutes to introduce our guest speaker, Dr. Juan Carlos Leoni. And Dr. Leoni is a consultant in the Advanced Heart Failure and Transplant Clinic, Division of Transplant Medicine, Mayo Clinic, Florida. He is also an instructor in medicine at the Mayo Clinic College of Medicine in Jacksonville, Florida, and Associate Program Director for the Advanced Heart Failure and Transplant Fellowship at Mayo Clinic, Florida. He did his internal medicine internship, residency, and chief residency at St. Elizabeth Medical Center in Boston. Did his general cardiology and advanced heart failure and transplant fellowships in Mayo Clinic, Florida. He is a recipient of multiple awards, at least few of them recognize his excellence in teaching, and he is co-chair of the Department of Transplant Diversity and Inclusion team. He's actively involved in the education of medical students, residents, fellows, and international observers that come to rotate in the Advanced Heart Failure and Transplant Clinic at Mayo. Actually, if you get a chance to read more about his bio, you would recognize that his non-medical interest and accomplishments are just as impressive. He's a marathon runner and ran the Boston Marathon in 2011. He enjoys swimming, hiking, soccer. He loves to learn foreign languages. He is interested in classical music and theater. And he's an avid reader, among few. I can mention even more. But we really appreciate Dr. Leoni joining us today, and appreciate his dedication to teaching and for finding the time, Dr. Leoni, out of your busy schedule to teach us about amyloidosis. So it's really our pleasure to have you here, and it's all yours.
Okay, thank you very much for the introduction. Most of those hobbies was now it's restricted. So, this is the first time actually I give this lecture, and we, before COVID, we started to form an amyloid work group here at Mayo. We recognized that the diagnosis and management of amyloid was going to be essential to our practice. So we met with a multi-specialty group that includes a hematologist, a nephrologist, a GI physician, a general cardiologist, and me. And we started to meet. And then COVID came. We kind of despair a little bit, but now we're kind of getting back together. And I think that's something that every institution might need in the future. Right? Have an appointed person to manage amyloid, depending on your capacity and your size. But this is something that we're going to see more and more often. I try to make a very practical presentation, really focus on a few cases that I've seen here in the past couple of months, and then we'll go about the importance of recognizing, at least having it on the back burner, that amyloid could be part of your differential for many of the cases you see in clinic, and then we'll briefly talk about what to do with this patient in terms of diagnosis, diagnostic imaging strategies, and then we'll talk about treatment. So, so again, I have no financial disclosures, no dinero, no money for this. Objectives: identify different types of cardiac amyloidosis, which is again the most common cause of death for patients with amyloid disease. We're going to enumerate underlying causes of cardiac amyloidosis, given differences in prevalences, genetics, prognosis, and management, and then finally some of the strategies for the management of TTR, cardiac amyloidosis, and of course AL as well. But I think TTR is where most people really are focusing their attention recently. So I'm going to present three cases. Okay, this is three people I have seen in the past couple of months. The first one is an 82-year-old Caucasian male. He had progressive concentric LVH, heart failure with mid-range ejection fraction of about 40%. Last year, he had was found to have complete heart block. Had a pacemaker placed, had a stent placed on a single vessel CAD a few years ago. Long-standing history of hypertension, AFib, hyperlipidemia. So things that you will find on someone this age. But the muscle, the echo showed some concerning signs that the heart was maybe thicker than is expected for someone with hypertension. So the outside practice, this is all people who have been referred from outside. So the outside practice, they decided to go ahead and do a an MRI of the heart, and that showed an LG pattern that was, had in the presence of LVH was strongly suggestive of cardiac amyloid. And then they follow with a PYP technetium 99 test, and that demonstrated also a positive, quantitative measurement of counts of the heart to contralateral lung of 1.59, more than 1.5 suggests amyloid. But they wanted to address, is this really amyloid based on this heart testing? So they did a fat pad, which was negative. The bone marrow biopsy was also negative. And then they did a kappa lambda free light chains, and the ratio was slightly high, was 2.08. So they referred this patient to me for a biopsy. So that's the first case. And again, this is just some of the tests of that particular patient. Again, the heart, especially if the septum is more than 1.2 centimeters, you might start thinking, is this amyloid? Again, hypertension, of course, is more common, but I think if you don't think about it, you might miss the diagnosis. So until a few years ago, we didn't have other testing than biopsy to assess if somebody has suspicion of amyloid, heart failure with preserved ejection fraction or diastolic dysfunction. We used to get many of these patients referred for biopsy, and we do about 700 procedures here in the procedure room, right heart caths and biopsies. We do more than 300 biopsies a year, and for post-transplant, it's easy. For native hearts, it's a little more tricky because you don't want to perforate these patients. They tend to perf more easily, so you have to be very careful when you do their biopsies. And once you have had a perforation on someone who in the past there was no treatment for amyloid, you're like, well, what is the point? It's not going to change the management. Just to know it's not enough. But now that things have changed and we have other diagnostic tools, we have the need for biopsy on these elderly patients really has dropped down significantly, especially with doing naturally a bone scan, which we do for many patients for osteoporosis, but that bone scan can be done in a different way with a technetium 99 technique, and we can actually have a highly suggestive, non-invasive diagnosis tech for cardiac amyloidosis. So that was the first case. Second case, this is again from 3 weeks ago, 85-year-old Caucasian female. She had a few comorbidities, and but interestingly, she was told she had hypertrophic cardiomyopathy many years ago, and concentric LVH, EF of 60% or so 3 years ago. She had some conduction issues, so she had a pacemaker placed 3 years ago. And interestingly enough, 13 years ago, she had been seen here in the clinic by hematology because her sister had developed a full-blown systemic amyloidosis involving the heart, peripheral nerves, autonomic nervous system, GI, etc. So she was being seen at the time by hepatology for possible liver transplant, which used to be a very common scenario for these patients with amyloid. The sister died, but then she came to the clinic and she had the genetic testing, and that was positive for P24S mutation, which is one of the many mutations that people with hereditary amyloidosis can have. But at the time, there was no treatment, so they said, you know what, just go on with your life, and we'll see what happens. Of course, patient gets evaluated again many years later with a local cardiologist, and they say, well, let's do a PYP scan, and of course, it showed that it was abnormal. So she was sent to me to say, okay, what do we do with her? She's 85. So this is a heart again. Not all hearts are gonna look super thick. When you see that, that's really, they're far gone. I mean, you lost your window. But if you have someone who, especially if they didn't have hypertension, they have a thick heart, you need to think about amyloidosis. In her case, again, she had some, she was deemed to have hypertrophic cardiomyopathy. That should be part of your differential. When in this case, if you have people that had HOCM with the phenotype that is not only the septum that is thick, but the whole heart looks thick, think about amyloid. So anyways, that's the second case. Third case, 68-year-old Middle Eastern man from Lebanon. I saw him about 3 years ago. He was referred from a local practice. Healthy throughout all his life, then he starts having bloating, shortness of breath, belly bloating, has a GI workup which was negative, X-ray with bilateral effusions. Echo has an EF of 55%, but again, severe concentric hypertrophy. So, and also an effusion, which for amyloidosis perspective, it portends a poor prognosis.
So they send it to me. We do a right heart cath. He has, of course, restrictive physiology with increased filling pressures. And he ends up, we do an endomyocardial biopsy. So it's positive for amyloid. We set that for typing. And the typing was abnormal. We also had troponins which were abnormal. We did free light chains with a very high increase of the lambda kappa ratio. So, and finally, we do a serum immunofixation, and that also has pretty much a monoclonal increase in his IgG kappa and lambda chains. So he's more classic case of AL amyloidosis. We did the full workup, ECG, low voltage, cardiac MRI, highly suggestive of infiltrated cardiomyopathy, and the bone marrow had 12% plasma cells. So this patient, which already from the get-go had a poor prognosis, he ended up being referred to hematology right away. And we did 9 months of cyclophosphamide with bortezomib and dexamethasone, and he did well. He was able to get into complete remission, and I saw him just 3 weeks ago, and the guy is doing fantastic. The heart's still thick, but there's no active plasma disease. So again, these are the three kind of cases that you're going to see, and we will at the end we'll discuss what we did with them. But these are the three scenarios that you might see, and if you don't think about it, you'll miss it, especially the first two cases. So why are we missing cases? Well, 75% of these patients have seen 3 doctors before the diagnosis was made. Usually 6 months to 63% at 6 months, more than 6 months to diagnosis, sometimes many years. 40% have to receive an incorrect diagnosis first. 31% require air travel to establish a diagnosis. And only 18% with cardiac AL had correct diagnosis made by a cardiologist. So sometimes we're reading all these echoes one by one, we read 30, 40, 60 echoes a day, and then you miss that thick muscle might have been AL. So cardiologists are the most common subspecialty to make misdiagnosis, okay? Differential diagnosis, HOCM, like that lady that I mentioned. So what is systemic amyloidosis? Again, it's an extracellular deposition of a fibril protein that misfolds and it deposits on many organs, including the heart. These deposits interfere with the structure and the function of the affected organs in the body. There's 24 proteins known to form amyloid fibrils in vivo, and for our particular talk, there's 2 predominant types involved in the heart. One is the AL, which is typically associated with a plasma cell dyscrasia, and then there's the TTR associated, the transthyretin, which is either mutation or wild type. And people get confused with these names because they have changed throughout time. The denomination has changed throughout time. So again, misfolded protein that pretty much becomes very, very heavy and deposits in the interstitium of the tissue. Like you can see here, all this pink material is amyloid, and of course that makes the heart, in this case, the heart very thick. And if you ever transplanted or explanted someone with a cardiac amyloidosis, usually when you take the heart out of the body for a transplant, most dilated cardiomyopathies, they just fall flat on the bucket. They're empty. There's no blood in them, so they just look like a piece of meat, very flat. When you take an amyloid heart, you put it on the bucket, and it keeps the shape of the heart because it's so thick. So that's just a very interesting finding that we see. And again, of course, with that infiltration, you'll see some changes in the cardiac biomarkers, and we'll talk about that at the end. So there's different subtypes of amyloidosis, and I think people get confused with this. There's more than 40 types of amyloid protein. The ones that we really want to focus on is the AL, which is, again, it's a light chain. It's related to light chains. It's a cancer. It's a malignancy. So plasma cell dyscrasia, when increasing the light chains, it can affect many organs. And the median survival is pretty low. And once we see patients with low ejection fraction, pericardial effusion, pleural effusions that have AL amyloidosis, the prognosis tends to be less than 6 months. So our patient number 3, actually, he was able to beat that prognosis. So again, the treatment, chemo, stem cell transplant sometimes. And then these 2 forms here, the ATTR M or hereditary, which is, again, it's a familial mutation that's in the chromosome 18. There's more than 120 mutations that we can see in that protein. V122L is one of the most common in African Americans. We can see it up in 4% of patients. If you have a patient in the clinic that is African American, maybe 4% of them will have amyloid, or this type of amyloid. Okay, median survival a bit better, 2 years, and again, there's this is the kind of patients that we tend to do liver or heart transplant combined in the past. And then the wild type, which is also called, it used to be called senile, mostly males, commonly those above the age of 75. You might see that they have the position of this protein in other organs, like especially carpal tunnel, spinal stenosis. When you hear someone having carpal tunnel disease, think about amyloid. I mean, just have it there in the back burner, because you know, some data have suggested that up to 10% of these patients with carpal tunnel syndrome, when they did biopsy of the tendon and they put it on Congo red stain, it showed up positivity. So you could even diagnose amyloid disease 10 years before the heart presentation. So that will make you look very smart with your colleagues if you can do that. Median survival, of course, is better for this type of amyloidosis, and the things that have changed is now there's treatment for this disease. Okay, so again, confusing nomenclature, and the reason is because there's a lot of amyloid proteins out there, but the ones that we're really looking into is the wild type, which is used to be called senile. It's a restricted cardiomyopathy. And then the AL, of course, which is a monoclonal gammopathy or immunoglobulin light chain gammopathy disease. And then we have the, actually this one, AF, which is the hereditary, which is the one that's called familial. And that one can have a range of disease from a neurological perspective or cardiac perspective. So that you might have seen FAP or FAC, familial amyloid cardiomyopathy or polyneuropathy, because some of them can have more of a neuropathic process or more of a cardiopathic process, or both. Again, AL, cardiac involvement in about 30% compared to the other types. One of the things that I get a lot is fat pad biopsies, and truly, unless you have AL, you won't find that in the other forms. And these are the forms that most people are seeing in the community. So fat pad will be, it's low yield unless you have AL. The primary referral source, hematologist, like the one that I got here was from hematologist, and then from the hereditary form, neurology, and the wild type or the senile, which again, mostly males, cardiology. There's many extracardiac manifestations in the three forms. We spoke a bit about neuropathy, carpal tunnel, spinal stenosis. And why is it so important to understand which form you have? Well, it's important because the survival will be different, okay? If you get someone who is 60, 65, and you miss AL, then you just reduce their survival. So it's very important to know exactly which form it is. And I think that's where most people get nervous about what to do with these patients. So reasons for missing diagnosis, well, it was thought to be rare. Well, not really. It's an underappreciated cause of HFMEF, heart failure with preserved ejection fraction, or low flow AS. There's a study that I'll mention later about aortic valve replacement and finding amyloid on some of these patients. And it's thought to be rare because people didn't think about it. But I think like any of these orphan diseases, now that we have better diagnostic techniques to see them, we might be able to do better assessing them and not missing the diagnosis. There's a misconception about the diagnosis that ECG is a good screen test, the low voltage. Well, that's a board question, but in true life, the ECG will be mostly normal. Again, fat pad analysis, high sensitivity, no, not really. Cardiac amyloidosis is a great masquerader. Every time we have a weird disease, myocarditis, sarcoidosis, tuberculosis, they always say a great masquerader, but you need to have the clues to kind of pick it up in your differential. Need for biopsy, again, as I told you, I've done hundreds, if not thousands, of biopsies, and I only perforate a ventricle one, and that was trying to diagnose an elderly patient with TTR cardiac amyloidosis. So these days, it's rare that we need biopsies. We still get those referring physicians saying, I need a biopsy to confirm the diagnosis, but there's other non-invasive techniques to do that. And, we thought it was untreatable. You have it, well, there's nothing we can do. Now there's some treatments and very effective if diagnosed early. So again, we'll go over each of the topics. Thought to be rare? Well, not really. AL amyloid, we see about 2,500 cases a year in the US. So, and again, 50% of them have cardiac involvement. The ATTR mutant or hereditary, again, it can be up to 4% of African Americans are carriers, especially here in the southeast of the country. So we expect that maybe there's up to 120,000 US patients. And then the wild type, this is the one that I think the older we see the population, the better things we do to make people live longer. I think we're going to see it more and more. And this is the one that's going to grow substantially. And that's why maybe having a specialist in your practice that deals with amyloid might be a good thing to start planning for. We might be able to see more than 1 million cases on those patients above the age of 80. Interestingly, worldwide, 50,000 patients with especially the mutant amyloid. The most common in the US, again, there's more than 120 mutations, defined mutations. The V122L in West Africa, we see here in African Americans, the T68, Northwest Ireland, the V30M in other populations, especially Europeans. It's autosomal dominant. So for that second case that I mentioned, that 86-year-old lady that had the sister with this mutation recognized 13 years ago, well, she might not have treatment because of her age, but it's an autosomal dominant, so you need to screen the family. So she has a daughter, she has grandchildren, so maybe 50% of them could have the disease, and if you can know that in advance, you can then treat appropriately. Okay. So again, and the other thing is that the penetrance is not always 100%. If you have it, doesn't mean that you're going to develop the full disease. And one example will be exactly case number 2, where the sister had a full-blown disease and she died 13 years ago, and the patient that came to us, she was still alive and with some symptoms, but not full symptoms. So the penetrance can be different even if you have the same gene. So again, multiple mutations that we see. There's a little bit of sex distribution that you need to know about. Again, the ethnic predominance might tell you where they're coming from. The cardiac involvement also might be different depending on the mutation. Some people can have more neuropathic symptoms like tingling in their hands, numbness, GI issues like gastroparesis. So you need to look for those. And compared to others which will have more of the cardiac involvement. So that's why, at least here at Mayo, we decided to do a multidisciplinary group. And when we see these patients, we refer them to our colleagues, because I won't manage the neuropathic portion. I will manage the heart failure portion. With the hematologists, they'll deal with the medications, the genetic testing. So I think in the future, we want to really make a physical space like many other institutions where you have an amyloid clinic day every Wednesday, and you have all your multi-specialty group there to see patients and discuss cases. And I think that many practices can really try to have that model, which we're trying to implement here, and it's also available in other places. Again, increasing recognition of ATTR, in other circumstances, 16% of patients undergoing TAVR, 13% of patients hospitalized with HFMEF, 5% of patients presumed to have HOCM, especially those elderly might have even more. 1 to 2% of adults above the age of 75. And again, why it's important to know? Because it can lead to a premature death if you cannot stop it, okay? So there was a few studies based on how to pick up these cases on things that are not related to you. Again, someone having TAVR or someone having valve replacement. Again, one of the studies that was published recently, the Unveiling study that showed that those patients with severe AS undergoing TAVR, there was 13% prevalence of ATTR, which did not affect mortality. So, now that you see patients with TAVR, maybe think, oh, maybe this patient has amyloid, okay? What about ECG and FAT-PAT? That's a classic. Well, it's a classic fail because, again, not the prevalence of low voltage among the 3 types of cardiac amyloidosis is really low, mostly on AL. And once you see it, I mean, you're far gone. You lost your window. So, again, don't be fooled by just thinking that because the QRS or the ECG looks normal, that the patient does not have amyloid. FAT-PAT, again, we said sensitivity for AL, 70% at best. And in other forms of amyloidosis, less than 50%. So it's a simple test. I think it's worth doing it, but just don't say, oh, well, your FAT-PAT was negative, you don't have amyloid. Great masquerader, well, maybe. So again, we talk a little bit about the carpal tunnel also. This was what the study I was referring to in a cohort of patients that had carpal tunnel release surgery. They detected amyloid deposits in 10% of them. So, you know, if you have, I know this is going to be a widespread practice where if you have carpal tunnel, every time that they release, they take tissue, can you send that to pathology and have a Congo red stain? Might be something that it could become a normal practice, because it's, again, you might be able to catch the disease much earlier. So if you have patients that had carpal tunnel release surgery, you know, they never were someone who was working on a desk or a computer or a mouse. I mean, start thinking maybe this patient has amyloid, especially if you find other things that might point you in that direction. You know, think hard on the echo. Maybe they have some neurological symptoms like numbness in their fingers. So you know, it's a company it keeps. You just can't have one single piece of evidence to make a unifying diagnosis. And again, it pretty much can compromise any organ in the body. Deposits in many places, especially of course the heart. Things on the physical exam that you will see. This was in New England this year. Amyloid in the uvula. Never seen it, but hey, look at the uvulas and see if they look thick and this color. The typical indentation from macroglossia, you know, I never seen it, but it's reported. Again, we talk about the spine. People who have spinal stenosis, release surgery, maybe think about it, especially with other concomitant things. We have the raccoon eyes or periorbital hematomas that we see that. I have not seen it, but again, all of these things are reported. So you know, you won't find classic findings all the time in physical exam, but you need to think about it if you at least look for them. So even the Popeye sign, you know, where they have the ruptured distal bicep tendon with wild type TTR. Again, I've not seen it, but there's a few reports on it. So you see someone with a Popeye muscle and think about it. Again, I don't mind out of sight. If you don't think about it, you don't diagnose it. So history on the exam includes, again, people with HFpEF that didn't have hypertension, especially men, those with right side heart failure symptoms, hepatomegaly, ascites, intolerance to medications. You add the ACE, the beta blockers, and they just cannot tolerate. They're hypotense. Maybe that's a sign. Okay, people with carpal tunnel, spinal stenosis, think about these things. Think about this potential differential. Imaging clues, again, the low voltage to mass ratio, MRIs if they have one, apical sparing. If you do echo with strain, you might see that. I'll show you a picture in a second. Low myocardial contraction fraction, and the PYP test. Cardiac MRI, again, it's, you know, I think it's becoming more and more available for many institutions, so you can see not only the thick muscle, but also the distribution, which is diffuse, but it might lead to the diagnosis of amyloidosis with a non-invasive test. Also, if you have normal sized ventricles, but dilated bilateral chambers, that also might be a clue to think about amyloid. You know, if you're hospital dosage training, again, strain is not always done in every patient that we do an echo. Maybe in the future with better machines, we'll do it on everyone. It takes maybe a couple of minutes to do it for your echo text. But I think that if you have this sparing of the apex compared to the rest of the ventricle, that's a sign that the patient might have amyloidosis. So again, not only reserved for amyloid disease, you can have people with chronic kidney disease, you can have people with other diseases like hypertension that might have the same pattern. But if you have it, and think about it, but you need to do it. You need to do the strain. If you don't do the strain, then you don't find it. So do we need a heart biopsy in every case? Again, no. I think that if you have if you do need to do typing for some reason, for example, AL amyloid, yes, you can do that. But I think we have enough diagnostic, non-invasive diagnostic testing that you could potentially do. Don't need a biopsy. Okay, so we reserve this for cases that are not quite clear. The PYP test is something that I think has been a game changer because you know, it's just really a bone scan. And with that bone scan, if you have enhancement of the heart compared to the contralateral lung, it's very suggestive of amyloid, and it's a simple test. So if you have someone who, you have some clues from the history, some clues from the echo, this is an easy test that you could potentially do, and it doesn't take too much too much time to get the result. Again, accepted non-invasive diagnosis of ATTR cardiomyopathy. Again, if you have unexplained heart failure, or you, of course, you carry a pathogenic TTR mutation. If you have an echo or cardiac MRI suggestive of cardiac amyloidosis, if you have, especially very important, absence of a monoclonal gammopathy, okay, you do a serum free light chain assay and serum and urine immunofixation, so SPEP and immunofixation. That's important because you need to rule out AL. Otherwise, you cannot miss a diagnosis. You cannot miss AL. And if you have, there's grading for this PYP test. If you have a more than grade 2 uptake, then that's a confirmatory test for amyloid. So those are ways to non-invasively diagnose ATTR. And if that's the case, you don't need a biopsy, and you can even get treatment accepted or approved if you have any of this. Again, we spoke about the PYP test. Again, this is just a new article that I put there, the reference for you guys to review. And again, we talk about, or we mentioned the grading. So again, there's a cascade. There's an amyloid cascade that starts from having amyloid deposits in the heart all the way to having systolic dysfunction. So, and this could be many months or years, usually years. So you don't really want to miss the boat and be in the systolic dysfunction portion. Once you have low voltage, once you have symptoms, then you might be out of the window of opportunity. So hopefully by getting together the case, having the clues, thinking about it, you might be able to have not even need a biopsy, but do testing that it's non-invasive, and you might be able to get to the diagnosis. There's different algorithms how to pursue amyloid in your clinic. So I'll show you a couple of them. These are from the AHA. You have, again, clinical suspicion of typical echo, cardiac MRI findings. So things that you need to do for sure, you need to do the blood testing to make sure that it's not AL. Okay, regardless of the age, if they're 80 years of age or so, and you think it's they have a mutation, of course, that will give you other clues, but always you need to rule AL. So once you do that, if you do the testing, the immunofixation, the SPEP, and that's abnormal, then yes, you consult hematology, and then we'll go to fat pad aspirate, bone marrow biopsy, because you're looking into AL, and the yield for this test will be higher. If amyloid is present, then you can type it, and then if it's AL, then you start treatment. If this is a no, the blood testing that you did is negative, then you can do the PYP test, and if it's confirmed and it's ATTR amyloid, you can do the sequencing with genetic testing and then define if it's a wild type or if it is hereditary, okay? Because the treatment also is going to be different if it's one or the other. And again, if there's clinical suspicion still for the case, then you can do a cardiac biopsy. This is another way, pretty much similar from the AHA. I found, so one of my colleagues, Dr. Nativi from Utah, I asked him, they have a more formal amyloid clinic for many years, and I asked him, well, what do you do with your outside referrings? I mean, what do you want before the patient hits your door, especially if they're coming from 5-6 hours away? So the things that the reference can do before sending that patient for suspicion of amyloid is really looking at the serum light chains and the immunofixation, the SPEP. Those are blood tests, and if you have a capability of doing the PYP test, the nuclear medicine cardiac amyloid technetium 99 test, if you have that, you already rule out the AL amyloid and confirm that at least on imaging you have cardiac amyloid, and then we can work our way from there with genetic testing and other things. So in this particular clinic in Utah, that's what they do for people who live in the many hours away. They just have this protocol of doing this test before they hit the clinic. So they might hit the clinic on a Monday and then see the hematologist, the neurologist, the cardiologist the same day, and then from there have kind of divide what to do with those patients with that basic information. Markers in cardiac amyloidosis, again, there's definitely they're going to be abnormal, and depending on their cutoff, many institutions have done tables for prognosis and survival based on that. So, for example, there's a few of them, a couple from Mayo Clinic, depending on the cutoff of the NT-proBNP and the troponin, that will give you stages, and those stages also give you a prognosis. So this is something that you can have on the back pocket just to have more information for the patients to say, your NT-proBNP is this, your troponin is that, and this is what your stage is, and this is your prognosis, depending on the type of amyloid they have. And the survival, of course, will depend on what kind of amyloid they have. If they have the light chain one, of course, the prognosis is measured in months to just a couple of years compared to if you have the ATTR form or the mutant form. Okay, the prognosis will be different. This is again more of the same. Just to follow up, you can follow the response also based on for AL, you will follow with bone marrow biopsy, but also you can follow with NT-proBNP, functional class, and troponin. Okay, so these are things that you can look into. So why bother? It's an untreatable disease. Why to do all of this? Well, it was. Now it's not. So what's the general treatment for amyloid cardiomyopathy, regardless of the cause? Well, diuretics and salt restriction. For heart failure, we say no more than 2,000 milligrams of salt a day. Most Americans average 8,000 to 10,000 milligrams of salt a day. It's not the salt in the shaker that represents less than 10% of the salt. It's really how food is prepared. If you have, you cannot have asparagus in a can, even if it's healthy asparagus, and be in a can for 3 years and not go bad. It has to have salt on it, even if you rinse it. So start looking into salt content. If you look at Kikkoman soy sauce, the red cap, it's 800 milligrams of salt with just 1 spoon. You put 2 spoons of that and you're done for the day. The green cap that's the low salt Kikkoman soy sauce, that's 600 milligrams of salt per spoon. So again, things can be very salty, even if they say low salt. So you need to give information to your patient about reading labels and how to interpret them. Diuretics relate for relief of symptoms, mineralocorticoid receptor antagonists, and of course loop diuretics. Calcium channel blockers and digoxin are contraindicated. So if you're adding those medications, and patients having a very difficult response, you might start thinking, is this amyloid? Okay, especially if they have HFpEF, even HFrEF, you add these medications and they have a bad reaction to it, maybe think about it. Okay, many of these patients are going to be intolerant to the usual HFrEF medications, ACE, ARBs, then Trestos, beta blockers, again, often intolerant. So they are associated potentially with worse outcomes. Anticoagulation in AFib, irrespective of the CHAT score. Okay, these patients tend to clot or have more an increased risk of cerebrovascular accidents from stroke. So you need to anticoagulate them. Anybody with amyloid, AFib, regardless of the CHAT score, you need to anticoagulate them. Hypotension, sometimes they're very difficult to manage, so compression stockings, Mildred can help. And then should you put an ICD if their EF is 33% and they have, TTR amyloid? Well, mostly it's the pacing function, because the amyloid will really affect every structure of the heart, not only the muscle, but also the conduction system. So you need to be aware of that. Maybe they need more pacing more than an AICD. So the treatment for AL amyloid, don't mess with it. Get a hematologist, okay? It's especially if I took the boards, the internal medicine boards right now, I wouldn't be able to pass the oncology portion because all the drugs are very even hard to pronounce. So plasma cell therapies, there's many of them. They have been evolving with time. One of the new agents is the DARA. We will say daratumumab. Again, they can respond well to these treatments, but that's the role of the hematologist of the group if you have a group treating amyloid. Okay, so that's one portion. Things have been changing in the past couple of years. There's new drugs that have been approved, not only for the ATTR wild type, but also for the hereditary form. There's pretty much 3 drugs that are currently approved right now. The TTR gene silencers, patisiran and inosartan, and the TTR stabilization stabilizes the protein, which is tafamidis. The flunicel has been mentioned many times, but it's not approved yet. We used to do liver transplantation. When I came here to Mayo, we had a patient with hereditary amyloidosis who his brother had died of cardiac amyloidosis, and he was listed for heart liver transplant. And unfortunately, he had an arrhythmia and died while waiting. So we used to transplant because the protein comes many times from the liver, And if you change the liver, then you pretty much cure the disease, at least the more production of protein. So we used to do liver transplant for amyloidosis in the past, and I haven't seen that in a while, and maybe it's because of these new drugs. There's other drugs that are being studied, but nothing approved yet. So, the ones that you're going to be talking about or hearing about, the tafamidis. Again, tafamidis was FDA approved for the wild type. So that first case of the gentleman, which had the thick muscle, and they wanted me to do a biopsy. Well, this patient could potentially be started on that medication, okay, based on these trials. And there's some inclusion criteria, of course, and the trial had some inclusion and exclusion criteria, but that's a medication that could potentially be provided to the patient. Little problem, it's very costly, and there has been a big war between clinicians and these drug companies, because these are all new drugs, very difficult for research and development to put them out there. And the price is really outstanding, and that's a problem for many patients, especially if this is a disease that we're going to see more and more in the future, more than 1 million cases in the future in the US. So that's a problem. The Flunitral, again, it's an NSAID. If you when you study your for pharmacology and in medical school or in mid-level school, you see that that's a drug that is there. We never use it. We always use ibuprofen and the other NSAIDs, but it's an NSAID, but it has been on the research arena for amyloidosis for many years, but it's not approved yet. Patisiran, again, that's the other drug, is FDA approved for the hereditary form with neuropathy. A little problem, it's a IV drug. They're now looking into a sub-Q form of it. So that's, and the cost is also, in the hundreds of thousands of dollars. So the problem with this, what used to be called an orphan disease, now that we have treatment, yeah, but you need to break the piggy bank to pay for it. And even if the insurance will pay for part of it, the out-of-pocket costs are unsurmountable for some patients. Then the last one is Inosartan. Again, it's an FDA drug approved also for the ATTR mutation with neuropathy, but it's also sub-Q. So, they're working on oral forms, maybe reducing the drug price, but that's I think the limitation that we have right now for these medications. So in a nutshell, you confirm the amyloidosis, and then if you have heart failure, you do the heart failure management, avoiding the drugs that might make the patient sicker. The disease-modifying agents, if you have the wild type, tafamidis, it's approved. If you have the variant or mutant form, then if you have cardiomyopathy, there's tafamidis. If you have the cardiomyopathy and neuropathy form, then you can use tafamidis and one of the other agents. And if you have the neuropathy portion, then patisiran or inosartan. If you have arrhythmias, again, medical therapy like any other patient for AFib and anticoagulation. And device therapy, really pacemaker for heart block, ICD for selected patients, and then even BIB for pacemaker-dependent patients. So how we accomplish our objectives today? Hopefully, yes. One, identify different types of cardiac amyloidosis, yes. Second, enumerate underlying causes of cardiac amyloidosis, given difference in prevalence, genetics, prognosis, and management, yes. Strategies for the management of TTR cardiac amyloidosis and AL, yes. So what about our initial patients? The initial gentleman that came with a PYP test, likely wild type. Again, he came here for a biopsy. Interestingly, I tried to do a right IG approach, and he had tortuosity on his right IG, and I couldn't do the biopsy, and I didn't consent him to have a biopsy from the groin. So, I talked to my group and said, do we really need a biopsy? No, we don't need it. We have enough information to say that this is for sure TTR wild type amyloid. So I sent him back to his local hematologist to treat him. And the problem is that many of these groups are not treating these patients because they don't know the drugs, they feel uncomfortable, they have not started a practice, and that's a challenge for many practices where they say, oh, I just don't match this kind of oncological or hematological problems. But I think at some point, each hematology oncology group might need to have an appointed person to deal with these patients, because we're just going to see them more and more. Case 2, this elderly female that had the mutation form with the sister. So, she's not a candidate for therapies, maybe for her age. she could enroll in a study. She doesn't have HFMEF, so it's a little bit of a difficulty. So I sent her to the neurologist, and she's about to be seen. But the important aspect of this patient is not the treatment for her, because she's 85, she's frail, etc., but for the daughters and the grandchildren. Okay, so you need to, same like hypertrophic cardiomyopathy, you need to test the family, because it's autosomal dominant, and 50% of the descendants could have the disease. The last patient, or a very good friend from Lebanon, he had, again, the bad form of it, the AL amyloid. He required a lot of treatments. He had a pleural effusions. We had to tap him. We had to keep a pigtail for months to drain his lungs. Abdomen was always distended. So he did quite well with fluid salt restriction while he got his management for the AL amyloid, and he's doing wonderful. He's in remission. He has been able to travel back to Lebanon before COVID. He has done quite well. So, some patients, if treated appropriately and aggressively, they can do quite well. So, in conclusion, the ATTR cardiac amyloidosis has transitioned from a rare, underdiagnosed, untreatable disease to more easily recognizable and treatable. The diagnosis continues to be made based on, unfortunately, it's still based on late stage disease. Once we see it, everybody can see it. So you need to think about it and have it as part of differential when you see patients with the clues that we mentioned before. So we need to improve awareness of the clinical manifestations and potential therapeutic interventions to improve prognosis and survival. The light chain cardiac amyloidosis, again, if recognized early, like our patient, they can do well and can be managed very effectively. And with the current aging population, the wild type, or used to be called senile, will become the most common form of cardiac amyloidosis. And with that, I'll step back here with a picture of Roraima. This is a flat top mountain that we have in the Amazon jungle in Venezuela. That's where that movie from Disney or Pixar, Up, was with the old man with the house and the balloons, was based on. So this is actually a true thing, and this is the highest waterfall in the world, the Angel Falls. And I was there before coming here for training, and unfortunately have not been able to go back, but hopefully I'll be there soon. So with that, I'll leave some time for questions and answers.
Thank you very much, Dr. Leoni. That was great. We'll just wait for questions. If you can unmute to ask a question, or you can just type the question, and I'm sure Dr. Leoni will be able to see it.
Juan, this is Brent Fideau. That was wonderful. Thank you very much. Question. One is you actually, we have gene silencers and you have gene stabilizers. I'm putting them in two classes. I saw a patient that you guys are actually taking care of for amyloid right now, and he is on the tophamidis. When do you go to the gene silencer? I know it's extremely expensive. Obviously, he's an older man. He's in his 80s. Is it depend on age, on symptom progression? When do you all make that decision to go from a stabilizer to a silencer?
Yeah, and the problem that we have with that is that many of these patients are on the medication because they were enrolled in the trials before. So whatever they were enrolling, then they kept that medication. And for example, I have a patient that came from Miami, and kind of a friend of a friend, and ends up coming here, and I hook him up with the hematology clinic, and he ends up enrolling the trial for the patisiran, which is IV. And he got it, he felt good. His brother actually had a more aggressive course and was in a wheelchair, so he was really had a better course from a penetrance perspective. And now that the study finished and now the medication was approved, he's now like, well, should I try tafamidis? Because I also have the heart condition, besides the neuropathy. No insurance. I don't think no insurance is gonna pay for the two drugs, because that would be like $1 million a year. Right. So unfortunately, and we have not compared both medications end to end. So I think it will depend on have you been enrolled in a study trial and how much of the neuropathy portion you have. If you have a fair amount of neuropathy, then having a patisiran or inotersen, that will be
maybe the goal. If you have mostly the cardiac condition, the cardiac amyloid, then the tafamidis will be the one that we'll use. But I don't think there's any, I don't know of any patients that have both drugs. And that's also questions that the patients have. Should I switch to the other drug because, you know, it sounds better, or it's a pill instead of an IV or sub-Q form. So, but that's why it's so important to have the discussion with the multidisciplinary approach with your neurologist and your hematologist. And that's our purpose, to have a physical space where we can discuss each patient, like the one that you're saying, which one should we, what medication should we use for this particular patient?
Just a second question, if you don't mind. You mentioned some subgroups that I thought about this in. One is, we all have patients that have idiopathic pericardial effusions. You go through your workup and you can't find anything. Some have LVH, but no other signs. I'm just wondering if you take that group and consider pyrophosphate scanning on them. I don't do that right now. We just kind of follow them. And number two, along those lines, we are seeing about 5 to 10% of patients that have the low gradient preserved paradoxical aortic stenosis, low gradient preserved EF. Whether those patients, you quoted the data showing that 14 to 15% of those patients have amyloid. Should we be scanning that group of patients, or are y'all doing anything like that? Taking a subgroup where you see something and working them up?
Yeah, again, I think that the testing, the PYP test is a low risk test. And I think that's why you are seeing more and more cardiologists doing the test, because, you know, you don't lose anything by doing it. And I have people that come here and they have, you know, essential hypertension for years, but you look at that ventricle, it just looks odd. It looks a little bit more thicker than expected. So I think that it's reasonable to do the test for screening, or you can also do the strain with the echo. And then if you have, you know, those clues, then you might get a diagnosis. I don't think it's any wrong in doing it. If you don't think about it, you'll miss the diagnosis. If you think about it, say, well, why not? Let's do it. And I have had a bunch of negative tests. You know, we see so many people that have hypertension and thick ventricles and African Americans, and I'm just looking at them and say, well, why not? So I have many of them tested. They were negative, so I'll say, okay, fine. I'll rest my case and then just treat them as hypertensive cardiomyopathies.
Thanks, Juan.
Juan, can you see that question from Dr. Island?
Oh, I
Under chat.
Actually, I don't have the question, the Q&A.
Okay. It says, the question is, can you give tafamidis, I don't know how to pronounce that, to wild type without neuropathy?
To the wild type, yes, of course. And that's maybe the percentage for most patients. Yeah, if you have the diagnostic testing, you have the PYP test, you have the right, most of these patients are going to be males. I think it's 90-95% of patients are mostly males and females. So if you have that, then you can approve it. They'll approve it for you without having to do a biopsy, as long as you have ruled out that they don't have AL. So very important, you need to rule out AL first. You don't want to miss that. You don't want to put someone on tafamidis and they have AL cardiac amyloidosis. And hopefully with the 3 cases I presented, that's pretty much the 3 cases that you might see. And you know, they could have mixed one in with the other. If that lady didn't have the genetic test, you know, she could have been deemed a hypertrophy cardiomyopathy for years, and actually she had amyloid. But if she came as face value without the genetic testing, and the PYP test was abnormal, then she's one that you might have felt, well, it could be the wild type, you know, she's 86, but she's a female, and that's a little bit unusual since most of the patients are male. And then she had the neuropathy, she had the tingling in the fingers and numbness. So then you start saying, well, should we do genetic testing? So if you had the genetic testing done, then you'll find your answer. I mean, many places might have a genetic counseling clinic. They might have the geneticist to help you out with that decision making. Alnylam, which is one of the drug companies that makes this, they have a some sort of genetic counseling that they can send you the kits to your office and you can potentially do the test there. Again, it just depends on who in your practice wants to do that. I don't think that everyone in practice should take care of amyloid patients because I think it's a subspecialty within the specialty. So you might want to appoint someone who is interested in that, and then that person can do the genetic testing from the cardiology perspective. But I think that the better course will be really to have a disciplinary group. And if you see big hospitals like Utah, like Mayo Rochester, they have a multidisciplinary group for this disease, either a physical space where they meet once a month and see these patients in a single day, and then they discuss cases for an hour, and go over their presentation and such on.
Do the radiologists need any special training, or can we just send them because it's a technesium scan?
Yeah, I think that they don't need any special training. I think most of them should be aware of amyloidosis. I mean, it's a hot topic, so I think they should be aware of it.
I have a comment. Number one, thanks for highlighting that anticoagulation should be offered to patients with amyloidosis regardless of their CHA2DS2-VASc score. And of course, I'd like to emphasize that also applies to hypertrophic cardiomyopathy patients. And my question, if you have a patient with asymmetric hypertrophic septum, let's say 1.6 centimeter, and no family history and no hypertension and nothing else, and in their 50s, do you recommend that patient to be screened with PYP test or look into possible amyloidosis, ATTR form?
Yeah.
No other involvement?
Yeah, I think the company keeps. Are there any other clues to suggest that they have amyloid from their physical exam, from their family history? Do they have a family history of hypertrophic cardiomyopathy versus a sudden death or conduction issues at a young age? So those are things that.
It's the actual patient I've seen. No issues, no past medical history, no significant family history. I think mid-50s, thick septum and nothing else. And 2 years apart, echoes stable. Everything is the same. EKG normal, no gradient, asymmetric hypertrophy. And I was just wondering and seeking your opinion in that regard.
Interestingly, I had a call from a referent 2 days ago, and kind of similar case, someone who was deemed as hypertrophic cardiomyopathy, and they even sent him for alcohol septal ablation, but the septum was not thick enough, and all these other comorbidities, and they put him on verapamil for treatment of HFMEF, and then the patient did worse, so they had to stop it. So they just called me like 2 days ago. I said, well, did you thought about amyloid? And they're like, oh, no, actually, no. So I said, well, why don't you do your due diligence, maybe get a PYP test, get this stuff, and then, see if maybe that patient has actually amyloid and not HFMEF. So again, I think that the diagnostic testing these days is non-invasive. It's a blood test. It's a bone scan, and you can also do an echo with strain. And if you have all of those and they're all negative, then maybe it is HFMEF. I mean, HFMEF is still out there. So I think since it's not the hot topic now in medicine or in cardiology with amyloidosis. Now you order a soup letter and it spells amyloidosis. You've seen amyloidosis everywhere, but there's still a lot of people that don't have amyloid. But I think we need to think about it when you have patients that might fit the criteria.
Thank you. Any other questions, anybody? All right, that will bring us to the end of the lecture. That was wonderful. Dr. Leoni, thanks again for your time and for a wonderful lecture. And thanks everybody for joining, and everyone has a great day.
Thank you very much. That was good.
Thank you for the invitation.
Thank you.